hasn't started yet?
No, it wouldn't.
Yeah.
All right, welcome to the AG Bell Georgia Spring webinar for families and professionals. This is our third webinar. We are very excited. We had about 150 people signed up, so that is one of our records. So that is showing that we're really getting the word out, and we're actually picking great topics that people are very interested in, families and professionals, because we want to make sure we accommodate everyone. Next slide. And you'll see our sponsors. So we are constantly supported by our sponsors, and we're really thankful for them, because without them, we would not be able to pull all these events off that we do. We do about 3 or 4 socials a year, and we do this webinar as well. And the support is outstanding. And we're going to, throughout this presentation, the next 3.5 hours, we're going to talk about our sponsors, but we're going to start, I think my next slide is introduces Advanced Bionics. And we are very thankful for Advanced Bionics, because they are providing financial aid so that we can capture this. That's an expense that we were not able to take on, but we wanted to make sure that was available for our attendees. And so I'm going to pass it over to Francisca so she can talk about Advanced Bionics. We're doing a little slide.
Hi, everyone. I'm Francisca Hernandez, a cochlear implant specialist here in Georgia. Next slide. And I just want to welcome you all to a world of powerful connections. Next slide. I'm excited to be here because it's a delight of hearing. Go ahead, next slide. There's a delight of hearing. The CCC-A is the world's first cochlear implant sound processor, specifically designed for children and their unique needs. Slide. Next. AutoSense-OS has brought children a powerful hearing experience, flexibility for their growing adventures, and ultimate ease of use with its automatic features. Next slide. One of Advanced Bionics' signature technology has been connectivity, being the first to connect directly to any iOS or Android smartphone, Phonak Roger technology, or other Bluetooth-enabled devices. Recipients have been able to stream both calls and music and audio to their cochlear implant directly. Go ahead. Next slide. So let me share one of the amazing stories of one of our recipients listening through Bluetooth connectivity. Next slide. Go ahead and hit next.
I think she can hit play.
Yeah.
Marble CI is so much better than my last processor. It allowed me to be able to hear in all different kinds of surroundings, especially because it automatically changes the settings for me. I love the Bluetooth setting feature. I can stream music, I can stream videos, I can stream everything I want. So I encourage you guys to use that feature.
Thank you. We can cut it there.
Processor, my old one.
And hit the next slide. It's an amazing how Marvel CI has brought so many of our families together, especially now with connectivity being an important aspect of both school, video calls, conference calls. So thank you so much, Georgia AG Bell, for allowing us to be here today. And we're always excited to be part of the webinar. Enjoy the sessions.
I can vouch that Marvel has been amazing for my daughter, minus the ability to Bluetooth to her iPad. And then she can't talk to me sometimes. She's more into the iPad than me sometimes. All right, so we're going to get started with our session soon, but we want to do a couple of housekeeping things, and we're going to talk about our board as well, because they have been tremendous to pull everything off to support our families and professionals. You will be muted and your video will be turned off. Only the panelists will be able to talk and be seen. We will provide a PDF of the PowerPoints after the presentation, and you will have access to this. We will put it in the chat at the end, as well as sending it out. If you have any questions during the presentation, there's a Q&A box at the bottom of your screen. You can submit that or have the question that you want to be answered later, we will not get to it until the end of the presentation. Then we will answer all those questions best we can in that limited time we have. And then back to the captions, if you go to the CC, you can bring up the captionist or the captions so that you can read the text while we're speaking. Those are the main housekeepings for that. Now for the CEU credits, which I know you guys have a lot of questions about. Once again, you can ask this in the Q&As as well, and you can contact Kathy, myself, or Nikki at the end of this presentation. So the CEUs, you have to be present the whole entire session. So we are going to see your names when you sign in, and you have to be present the entire session that you want a CEU credit. And then after the presentation, we are going to send out quizzes. You have to make an 80% or better, and you will be then send out a certificate. We're going to give you guys 1 week to take that quiz after the presentation, and then we will send out certificates afterwards. Kathy Newbern has been amazing and applying all this. She's with Atlanta Speech School, and she was able to make sure that we got all these credits. AG Bell is one of our sponsors, and they are actually making this free for everyone and allowed us to cover that cost for LSL Sky credits. And then ASHA is going to be a verification form that we're going to send to you guys that you're going to submit on your own. I know that was a lot, so we will go through this again at the very end. If you have questions, we'll stay on for you as well.
One important point, Sherry, is that we'll only be sharing the links for the evaluation quizzes during the webinar. We will not be sending those out afterwards. So please make sure to open those links or save those links to take that quiz. It's only 10 actual questions, so you can probably do it while we're all online here. But just a reminder, if you don't access that link during this webinar, we will not be sending them out again.
That was a very important question. Thank you, Nikki. Link only provided during these sessions at the end. We are not going to send them out later. Hope people got in early to hear about. All right, so as we were saying, we are the Georgia chapter of AG Bell. We stay connected by doing a bunch of socials. We do webinars. We post a lot of things on social media, and we've really grown from where it started with Linda and Sarah, who have been amazing with starting it, and we've built a great board. And that's where I'm going to introduce next on my next slide. Because we try to stay connected. There's times that families and professionals feel very lost and don't in this world of hearing. And so we want to make sure everyone has ability to stay connected. Our last social, which Jessica and Jonathan and ABC and Atlanta Speech, a lot of people joined us with, Chris, and it was wonderful. We had one of our biggest turnouts. I think we had over 30 plus families, and people just loved it. We partnered with YMCA. They gave us their facility for free. So we really want you to tell your families or peers that you know that want to find ways to stay connected with other families with hearing loss, so that we are doing these activities and these socials to stay connected. And right here, you see my board. They have been amazing, and nothing happens. I do not do everything by any means. It is this board, and they have been the glue of everything. And I want to give a special shout out to Nikki, who has, hands down, she's amazing. She is behind the scenes, making sure that all the documents are for this webinar, making sure that anytime we send out stuff, it's wonderful. Samantha does a great job of promoting it, and just together, it's just been a dream team. So thank you to my team that is committed and volunteer their time. I'm going to wrap it up. So we're gonna, these are the presenters today that you've probably seen through the all the agendas we've sent out. We're very excited about our presenters also volunteering their time. The topics were seeked out because they're just hot topics. And I'm gonna start with Dr. Erin Holman, because her topic is very hot with unilateral hearing loss. And I know there's a bunch of families and professionals on this call to learn more about it. So next slide, so you can see her bio and see how wonderful she is. She's a pediatric audiologist and she works for Children's Healthcare of Atlanta. And I am so honored to have her. And she is sitting here right next to me, and she's going to take my spot and lead you guys in a great presentation for the next hour and a half. Once again, chat, Q&A, and then the link is going to be provided. We're going to take a second to share the screen. So Erin's, of course, now I don't have it. What did I do with it? Wait. I'm not going to share my screen until. All right, it's definitely not that. Here it is. Sorry, you guys. All right. Presentation, right? All right, let's do this. I'll help you move it over. You know this better than me. They can't see the screen right now. Let's see. Yes. What I wanted to do the audio. Oh, we can't do the audio until. Open this. Yeah. So share. Yeah, perfect. Was it already on? It's crazy. Presentation, yeah. Yay! You got this. Very exciting. I'm excited to hear it.
All right. So I'm Dr. Erin Holman. I'm an audiologist at Children's Healthcare of Atlanta. I've been in pediatric audiology in the area for over 10 years, and unilateral hearing loss is definitely something that I have a passion for, and it's an area of our field that is, like Sherry said, kind of a hot topic at the moment. And as a general population, children with unilateral hearing loss have not been, they maybe been overlooked for some years, but right now I think it's kind of their moment. So here we go. So first off, what is unilateral hearing loss? Unilateral hearing loss is described as a hearing loss in one ear with completely normal hearing in the other ear. You can have any degree of hearing loss in your impaired ear. You can have a minimal or a mild hearing loss all the way to a severe to profound hearing loss. There is a subset of unilateral hearing loss that is better known as single-sided deafness. And this is where we have an ear on the impaired side that's really not adequate for speech understanding. It's described as having a PTA or an average of hearing loss of 70 decibels or worse, or word recognition or the ability to understand words at an audible level of less than 60%. So enough hearing loss that we cannot understand what people are saying into that ear. Oh, goodness. Just a second. Okay, how much, I cannot read the top of my slides, I apologize. How often do we see unilateral hearing loss in kids? In the newborn period, it's about 1 in 1,000. But what's interesting specific about unilateral hearing loss is we see that more and more of them come out of the woodwork as they get older. By the time we reach school age, it's anywhere from 3 to 6 in every 100 children that have unilateral hearing loss. There's been some interesting studies to look at the prevalence of hearing loss, and we find that as they increase with age, that more in, there's been some interesting studies that show that a lot of kids with unilateral hearing loss actually will progress to bilateral hearing loss, as many as 1 in 10. So making sure we keep an eye to monitor and at the very least monitor the good ear of these children is super important. There was an interesting study done that looked at the population as a whole in hearing loss from the early 80s, early 90s to the early 2000s. We see an increase in hearing loss from 15 to 20%. And then inside the subset of unilateral hearing loss, 11 to 14. So the incidence of unilateral hearing loss is definitely increasing. What all these numbers mean in the real world, in a typical classroom of 30 children, we could in theory have up to 4 children with unilateral hearing loss in that classroom. So there's a large population here. And it's important that we capture them and give them what they need in those formative developmental years of school. So before universal newborn hearing screening, the typical age of identification for unilateral hearing loss was actually that kindergarten screening. We would do their hearing test to make sure everything was working well in kindergarten, and we'd find hearing loss. After universal newborn hearing screening, we've seen that we are catching a lot more of these kids at birth. Our detection was going from 3% at 6 months of age to upwards of 42% at 6 months of age. So we're capturing this population at a much younger age and trying to figure out kind of what to do with them at a much younger age. The average age you can see of diagnosis has declined from 4.5 to 2.5. So we've got kids that are entering kindergarten, have developed language, and now we've got kids that are developing language that we're finding with this unilateral hearing loss. So what are some of the causes of unilateral hearing loss? How did I do that? Here we go. There we go. Cochlear nerve deficiency is actually one of the more common causes of unilateral hearing loss, specifically the more profound or that single-sided deafness. What that means is that the cochlear nerve that runs from the ear to the brain is not formed fully. So instead of being a nice, robust, round nerve, we've got like a diminished nerve, or it's only like 25% diminished, or it's not there at all. So what that means is we do not have a pathway that goes from the ear to the brain to send the sound to the brain the way it's supposed to. Another cause, which is currently also another very hot topic and being studied a lot, is congenital cytomegalovirus, or congenital CMV. As we study more and more about this population, we are starting to realize that the number of kids who had congenital CMV as potentially a cause of their hearing loss might be a lot larger than we initially thought. Congenital CMV affects approximately 1 out of 100 infants. It is a cold. It's, you get a cold while you're pregnant and it happens to be the wrong cold. And so the child is exposed to it. Inside that, we don't understand everything altogether. I personally have a set of twins. One of them has congenital CMV, the other one does not. So there's still things that we're learning about it. But what we do know is that the kids that we're able to classify and find out have congenital CMV, they are at much higher risk of hearing loss than kids that do not have it. The other thing that's challenging about this is that up to 90% of the kids who have congenital CMV are actually asymptomatic. So they don't have really any symptoms affecting any other systems, in their body. So it's not something that's picked up without a test early on. Of those asymptomatic kids, we find that anywhere from 6 to 23% of them actually develop hearing loss in childhood. And of the kids that are symptomatic or are showing sort of other body systems that are being affected by the CMV, that population, anywhere from 20 to 65% of those kids will develop hearing loss. So it's a high proportion of these kids that are developing hearing loss over time. I know there's a real push from the National CMV group to try to get this screened for all kids at the hospital, because like 90% of them have no symptoms. But if we know we need to watch them for hearing loss, 25% of those kids could develop hearing loss. So I know there's a large push, and it's probably not a terrible idea.
Yeah. First 21 days though, right?
It's early. You have to test it very early because again, it's a common cold. So once you've got a kid who's been out in the world and had a few colds, they'll test positive for it. And we won't know if they had it in utero or if they had a cold. So it's a little bit harder to tease out after they've been around for a while. Malformations of the ear canal is another common reason for unilateral hearing loss. Those are your kiddos that have microtia or atresia, where the outside external ear, there's no hole and there's no ear on the outside. Those are obviously quite easy to tell because you're physically missing the ear. It tends to be a unilateral issue, and it does tend to happen more often in males than females. And it is actually something that normally we see those kids pretty early because, again, they're missing an ear. So it's quite obvious that we need to intervene. Bilateral bacterial meningitis is another common reason for unilateral hearing loss. It's oftentimes people think of this being something that's going to affect both ears at the same, but actually more commonly, we do see unilateral hearing loss or asymmetrical hearing loss in these kids. In large vestibular aqueduct syndrome, we found that upwards of 23% of children with unilateral hearing loss actually have this malformation. There is a tiny hole in your cochlea that leads from the brain to your ear. That's how the fluid gets into your cochlea. And sometimes it's too big. And if it's too big, it can create imbalances and cause hearing loss. What's interesting is that a lot of these kids who have unilateral hearing loss because of EVA also actually have bilateral EVA. And so these might be some of these kids that we're seeing progress to bilateral hearing loss as they get bigger. Ototoxicity, chemotherapy, antibiotics, those can affect just one ear instead of both. Again, I don't know that we know exactly why that is yet. We're trying to figure it out, but it does happen. Genetic hearing loss is obviously another factor, and then normal risk factors for hearing loss like premature birth as well. Okay, kids are not tiny adults. So why is this important? You know, you meet an adult with unilateral hearing loss and they do just fine, they compensate great, but then we're worried about all these kiddos. And it's because they're not tiny adults. We go into a party and we walk in and the host comes up to us and says, "Hey, put your cat in the closet." We go, "What on earth are you talking about? Put your cat in the closet? That makes no sense. Your cat, hat, bat, coat. Oh, I'll put my coat in the closet." I misheard what he said. We're using the information, knowledge, lexical dictionary that we've built over our life of listening and learning to realize that he did not tell us to put a cat in the closet, that does not make sense. What did he say? And we're figuring it out. If we've got a kiddo, they do not have that database because they have not built it. So when they hear, "Hey, put your cat in the closet," their response is, "I didn't bring my cat." And everybody is confused, and the kid is confused, and the person's confused, and we're all very confused. So it is important to realize that kids are not tiny adults. The effects that a minimal hearing loss or a unilateral hearing loss might have on an adult is not necessarily going to be the same as what it's going to have in a child developing speech or learning new things in school. So why are two ears so important? We have lots of advantages by having two ears. So we have something called binaural summation, which is actually a phenomenon where when we put sound in one ear and then put sound in both ears, our brain actually perceives sound as being louder when we're hearing it in both ears, even if the sound is the same volume. Our brain actually kind of brings it together and gives it a boost by hearing it on both sides. We also have the head shadow effect, which is exactly what it sounds like. Sound comes to your right ear, and then it moves up over around your head and goes to your left ear. And that delay in timing, as well as the delay in volume, is called the head shadow effect. The head actually blocks some of the sound from getting to your other ear. That helps us with things like localization and things like that. But if we only have one ear, now all of the sounds from this side are coming in at a later time and at a softer volume. So that can definitely have an effect. Again, localization. So our brain uses cues from things like the head shadow effect. It's like where the timing of sounds come into. Did it come in faster on this side? Did it come in faster on that side? Is it louder on this side? Is it louder on that side? To help us figure out where sounds are in our environment. If we have an ear that is not contributing the way it's supposed to, then we find that people with unilateral hearing loss will often observe all sounds from coming from their better hearing ear. So you'll see kids who are unaided with unilateral hearing loss often do like a spin to find people. You'll call their name and they'll do, "Where did they go?" Or you'll call their name from the kitchen and they'll head to the family room. And you're like, "Why are they going the wrong way?" And it's because they're not able to identify where the sounds are coming from. On a side note, this is an extremely important thing to talk about with your kids with unilateral hearing loss, because if a car honks at them in the street, they look the wrong way. So making sure we're teaching our kids proper safety in their environments is also extra important for these kids that have unilateral hearing loss. Spatial release from masking. Sounds like a crazy hard concept, but really what it means is if we separate the noise from what we're listening to, our brain does better. So if we are able to take what we're listening to and move it to a different spot from where the noise is that we're trying to compete with, it makes it easier for that person to hear and understand what that person is saying. And then we also help them in reverberant situations from a similar concept to spatial release from masking. So the impacts of unilateral hearing loss on children, because children with unilateral hearing loss do not hear the full picture, they're missing part of their world. They're more likely to experience difficulties in speech and language delay, general communication difficulties. Someone tells you put your cat in the closet and you get real confused. Psycholinguistic dysfunctions, so the ability to learn language, social emotional problems. It's not uncommon for these kids to feel bullied because they mishear things, or they miss the punchline and think they're the punchline and things like that. Quality of life, which kind of goes into all of that. If you're struggling with these things, it can affect your quality of life. And then academic and behavioral difficulties. These are all things that we have studied and found that kids with unilateral hearing loss have difficulty with. So even though they hear from one good ear, it doesn't mean that they don't struggle.
Mhm.
So if we look at some of the differences we see in some of the studies that we've done, we have a study by Liu and colleagues that looks at the effects of unilateral hearing loss on speech and language scores in children. They had an interesting way of setting up their studies. They actually did sibling pairs. So they had a sibling with normal hearing and then a sibling with unilateral hearing loss. And what that was able to do is it was able to get rid of some of the confounding factors like maternal education and SES and things like that, and really try to isolate that unilateral hearing loss, the difference between the two siblings. Inside the group of unilateral hearing loss, we found that some of them were aided, some of them weren't. There was varying degrees of hearing loss. It was just hearing loss versus normal hearing peer or sibling, excuse me. They administered the oral written language scale test. And what they found is that the children with unilateral hearing loss scored worse than their siblings in language comprehension, oral expression, and oral composite. So that's kind of, to some extent, the higher level language, not necessarily how well they talk, but how well they're taking that language in and using that language. They did find that family income and maternal education did play. Oh, sorry. They did find that family income and maternal education did play a factor in the scores, but there was still that difference between the siblings. Oh, sorry, sorry, captioner. We looked at there's a different study that they did to follow up. That was, again, a sibling controlled study with 107 sibling pairs. And what they looked at this time was actually degree of unilateral hearing loss. And again, they found that the unilateral hearing loss had worse scores than their siblings. And that the more significant the unilateral hearing loss was, the worse their scores. So our kids with profound unilateral hearing loss did worse than the kids with mild to moderate loss. So, we've got some studies that support that these kids are struggling as well.
Yeah.
Quality of life. This was an interesting study because it did compare children to parents as well, children's quantitative device as well as parents, and then also looked at unilateral hearing loss versus bilateral hearing loss. What they found was that those with unilateral hearing loss scored poorly on several scales when compared to the normal hearing peers or their bilateral hearing peers or bilateral hearing loss peers. So the lowest scoring group was actually the group with unilateral hearing loss. They were the ones that were noticing the largest quality of life difference. The author concluded that children with unilateral hearing loss demonstrate an overall lower, wider range of quality of life scores compared to their normal hearing peers and their bilateral hearing loss. It sounds a little counterintuitive, I think, to think that these kids with unilateral hearing loss that are able to hear so much more than some of their bilateral hearing loss peers would have lower quality of life. But it kind of makes sense if you think about it, because depending on where you sit or stand or interact with a person with unilateral hearing loss, you could have a completely different experience with them. So if you were sitting on their better hearing side and having a conversation in a noisy room, it could be like there's no hearing loss at all. But then you go to the other side and now it seems like they're ignoring you and they can't hear you and they're not paying attention. And so I feel like because you don't always get the same situation with them, that people are more apt to say things like they're not paying attention or they're being rude and ignoring and things like that. And so you end up with a lot of social sort of conflict, I think, in a lot of these situations that you wouldn't necessarily see with a person with bilateral hearing loss, because they're like, oh, they have hearing loss, and they kind of give them a little more grace maybe than the kids that have unilateral hearing loss.
Yeah, I can
Because
see
it's
that.
easier to make the mistake, because on one side they do great and on the other side they don't. So academic difficulties. This is sort of older data, and this is, I think, what probably lit a fire under a lot of people to really start to look at this population. Is children with unilateral hearing loss have a higher incident of failure rate in school and negative comments on their report cards. Teachers in general typically rated these children more negatively than the normal hearing peers. There were concerns about their ability to pay attention in a classroom, their abilities to relate to their peers, their independence in a classroom, and their emotional abilities. All of these things are things that teachers would negatively rate unilateral, more so with unilateral hearing loss. We also found in a similar study that there was more common for these kids to have behavioral concerns put forth by the teacher as well. Then we look at a meta-analysis from several studies in the area of unilateral hearing loss. And what we find is children with unilateral hearing loss have a much higher incident of failing a grade. They are typically higher at potentially needing more assistance to like a IEP to actually have academic success. And of those kids that require academic help, we'll go with that because I can't find the right word. Those kids are more likely to be the ones that are failing the grades. So there's a group of these kids that are really struggling in the classroom. They're 10 times as general more likely to repeat a grade, and 5 times more likely than their normal hearing peers to need additional educational resources. So just because they hear well in one ear is not enough for them to be successful in the classroom. There's definitely something that is more challenging for these kids. And what's sort of the big question mark is which kid is going to be that 50% and which kid isn't, and trying to figure out which kid's going to compensate great and which one's going to fail a grade. And so we're all working to try to figure out that puzzle of these kids. So we talked about all the benefits of binaural hearing, and now we look at a typical classroom. I personally think this is probably underestimated. But if you look at this study from 2004, 140 classrooms, one teacher speaking at the front of the classroom, everybody sitting still, 60 decibel classroom. Students are sitting doing group work, boosts up to 73. Students are doing group work and moving around the classroom. Now we're up to 77. Or the teacher talking and we're simply moving around. This is 72. These are very quiet children, in my opinion.
Not typical.
Yeah, so I'm thinking we're probably higher than that in most of our classrooms. And then if your kids' classrooms are anything like my kids' classrooms, they're doing group work, but they're all doing different group work. So we've got some kids on the computer and some kids doing math and some kids doing this, and they're all moving around and asking questions and doing different things. And so it's an extremely dynamic classroom. And it can be really difficult to listen in those situations. And if you think about going to a big lecture hall and listening to a meeting like this, or if your audio is going in and out right now and you're not able to hear what I'm saying, you are probably starting to tune out and work on your grocery list because you cannot hear what I'm saying and it's frustrating and you're like, whatever, I'm just going to do my own thing. So now imagine your 8-year-old child in a classroom and cannot understand what the teacher's saying and is supposed to be doing phonics, and they start drawing Pikachu instead because they cannot hear what's going on and they're like, oh, this is too hard, and they kind of give up a little bit. It's human nature. We do it as adults, and now we're asking these kids to behaviorally manage themselves and also learn all this content in a situation where they can't hear what's going on. And what a tiring, exhausting experience that they must be living. And then we're like, oh, this kid can't attend in the classroom, it has ADD. And you're like, no, the kid can't hear what's going on in the classroom. So yeah, it's a real issue. So what should we do? Although there are a lot of audiologists and ENTs that are definitely coming on board that unilateral hearing loss is a real difficulty, there is still work to be done. And there are still physicians that are like, well, they've got one good ear and things like that, and audiologists who won't fit mild losses and things. So it's definitely an area that we need to continue education. The American Academy of Audiology does have a statement about unilateral hearing loss. It's as clear as mud. The use of hearing and aid amplification is indicated for some children with unilateral hearing loss. The decision to fit a child with unilateral hearing loss should be made on an individual basis, taking into consideration the child's or family's preference, as well as audiologic, developmental, communication, and educational factors.
Yeah.
So kids with unilateral hearing loss may or may not need a hearing aid, and we should take all of their things into consideration. So there's not a lot of guidance on what to do with these kids.
Not black and white.
It's not black and white. All of these kids are very gray. You know, it really depends on the kid and their situation and their hearing loss and their needs. So how do we evaluate that as audiologists? All right.
Aaron.
Okay, so signs of unilateral hearing loss. In young kids, sounds of unilateral hearing loss can be trouble finding sounds. Like we talked about, you call them from the kitchen and they go to the living room. Why are they going the wrong way? Problems understanding speech in noisy places. You're at Chuck E. Cheese and they have no idea what you're saying. And then problems hearing you from the other room or from outside. All of these things are things that my normal hearing 4-year-old does. She doesn't come when I call her. She doesn't pay attention to Chuck E. Cheese, and she does not come when I call, doesn't do what I tell her when I'm from the other room. So it is extremely reasonable, I think, to have parents who have a 4 or 5-year-old who are first identifying their hearing loss and have no idea that their child has hearing loss. I've heard several times stories of kids that are handed a phone or headphones, and the kid's like, oh yeah, this one doesn't work. And the parent's like, I'm sorry, what? And they're like, oh yeah, this one's broken, it doesn't work. And it's perfectly normal to the child because they've never heard out of that ear. So they don't know both ears are supposed to work, but the parent's like, no, both ears are supposed to work. And so that's not an uncommon thing to see a 3, 4, 5-year-old child whose parents are like, they said their ear doesn't work, and come to find out it doesn't. When your child has trouble hearing, things that you might see that are not necessarily like what you think about with hearing loss would be getting upset and not being able to hear. So getting frustrated, being really tired at the end of the day. It's normal for a kid to come home and need 10 minutes to decompress. It's a different thing when your kid comes home and takes an hour-long nap and they're 9 or 10 years old. Having trouble paying attention. So your kid looked like they have ADD. They can't stay on task. They are, having trouble staying on task at school, things like that. Answering the wrong question, put your coat in the closet. I didn't bring my cat. That makes no sense, but that's what they heard. Acting out, having tantrums, being frustrated. I mean, again, how frustrating it would be to live in a world where everything is not coming in as clear as it should, but you're expected to hear everything. And then turning things up to make it easier to hear.
Do they tend to speak louder?
The child's volume, I think, is based more on the child. I have not seen a huge difference in how loud the children talk based on any hearing loss, to be completely frank. They tend to just be boisterous children or more mild-mannered children.
Fair.
So, yeah. Okay, so when we are testing a child for unilateral hearing loss, our audiology workup should, in theory, look like a comprehensive audiogram, which is doing a complete hearing test with both air conduction, which is through the earphone, and bone conduction, which is through the little headband that we put on. Word recognition, how well they're understanding, ideally in both ears, in the good ear and the bad ear. And then if they're able to do it, some speech and noise testing, looking to see how well they're doing in those noisier environments. So that's sort of the ideal workup. Now, if you have an 18-month-old, obviously that's not going to happen. But as soon as we're able to get to where we're able to do that whole workup, that is kind of what we're looking for. From the ENT side of things, my opinion is that every child with unilateral hearing loss absolutely 100% needs to see an ENT, and that they absolutely 100% need to have imaging. We have something different on one side of the body than the other side of the body, and I think it needs an image. Whether they decide to do a CT or an MRI is up to the ENT, and can depend on like what type of hearing loss we're finding as to what type of information they're looking for. But I do think imaging of these children is important because it can hugely influence not only whether we're monitoring them really close because we think they're definitely going to have bilateral hearing loss, or but also some of the technology and options we have for them in the future. The ENT workup also will include oftentimes a kidney ultrasound for our kids with microtia and atresia. There is a higher incident of kidney issues with those kids, so that's something we can check. And then if they are young enough, we will try to get that CMV testing done. Typically, if we can get it in before the first 2 to 3 months of age, that's ideal. Sometimes they'll test it bigger. We did have a kiddo that was 5 come in the other day with a negative CMV test, and you're like, sweet, it's not CMV. So sometimes they will test it later, but and if it comes back negative, great. But if it comes back positive, you're kind of like, we don't know still. So it's definitely better to do that testing on the front end as early as possible.
Is it still a urine test if it's tested later?
No, it's typically a blood test if it's
Okay.
tested later. And so I know what our clinic does is do the urine test. If it comes back positive, then they will try to access the dried blood spot from birth and test that initial test. So, which is a whole nother ball of worms.
Yeah.
And then last on the workup is genetic testing. I think a lot of our ENTs will kind of leave that towards the end, unless there's another reason to, like family history or something like that. But oftentimes, if you look at sort of those common reasons of unilateral hearing loss, those imaging and CMV cover a large portion of them from the beginning. And so if we can save the money on genetic testing and the effort on genetic testing by finding out that they have EVA on both sides kind of thing, that is sometimes we would kind of do that as a secondary test for this population, where it might not be that secondary test for a bilateral kiddo. Okay, so I talked about speech and noise testing, and this is how our center does it. We have a test stimulus or a target sentence that is presented at 50 decibels, which is average conversation speech. And then we have a noise source, which ideally is like multi-talker babble, which is like being in a restaurant and hearing lots of people talking. And that is presented as a noise source that you have to combat. We present our noise source 5 decibels softer than the target source. So we call that a +5 signal noise ratio. So what they're listening for is a little bit louder than the background noise, but it's a lot of noise in the room. In the first condition that we do speech and noise from the front. So both ears are getting it equally. It's called 0 degrees azimuth. And we have that lack of spatial separation, which makes that a little bit more of a difficult task. And we look to see, without any amplification, how they're doing in that situation. We then switch it up and we put the speech or the target speech into the better ear and the noise into the impaired ear. This should be ridiculously easy because the noise should honestly be softer than we have it programmed because they're not hearing it as well. And all of the target should be very easy to hear. So we expect these scores to be near perfect. And the reason we do it is because when we add a hearing aid onto it, we expect those scores to remain perfect. And if in some of our populations, we find that when we add technology, we can actually make it a little bit harder because we're adding more noise to their world also. And we do see a population of kids that when we add more noise to their world, they actually do worse instead of better. So this is kind of a way to make sure that technology we're adding is not making it harder for them. And then the third condition is the hardest condition. And I will always warn my kids and be like, this is going to be so super hard. Just do your very, very best. And this is where we present the speech to the impaired ear and the noise to the better ear. And this is super duper difficult. And this is where you see huge variability in children and in people in general. I have some kids that cannot do it. They get like a 0. And I tested a kid the other day who got a 96. So it's not necessarily hearing loss dependent, but there's a huge range. And so it's important that we kind of look at this so we can better assess sort of what to do next. We recommend using a developmentally appropriate open word set, or ideally like a sentence test like the pediatric AZ Bio or the QuickSend. So that's what we're doing with our testing. Managing unilateral hearing loss. We have lots of choices. If we have a hearing loss that can be aided, we can put a hearing aid on it and we can fix the hearing loss. If we have an ear that has microtia atresia, we can put a bone conduction hearing aid on it and we can fix the hearing loss. If we have a profoundly impaired hearing ear, we are starting to offer cochlear implants for that population. And again, we can fix the hearing loss. And then we have a group of people that we cannot fix the hearing loss for. And those are the kids that have like cochlear nerve deficiency and things like that. And we have an option to do like a contralateral routing device or a cross device. In those situations, what we're doing is providing better access to sound from the impaired side. So if my left ear is hearing impaired and my right ear has normal hearing, we put like a remote microphone on our right side so that the right ear can get sound over here a little bit faster, a little bit easier. But in no way are we correcting the hearing loss. We're providing better access to sound to the normal hearing ear.
Like surround.
Mm-hmm. And then the last option is to monitor. Some kids really compensate quite well, don't want to wear technology and do well, which is monitor to make sure everything continues to stay normal. And that's not a bad choice for some of these kids. So I think to understand what all the different options are, we also have to understand like the path to hearing in general. So typically we have the outer ear, and then we go to our middle ear, which is the ear bones in the eardrum. And then that sound moves on to the cochlea. And then you can see the nerve coming off the cochlea, which takes it to our brain and we get sound. So the sound comes in, goes through the whole system and makes it to the brain. When we have sensory, I'm going too fast. I keep getting hand waves by Sherry. Sorry. When we have sensory neural hearing loss that can be aided, we are typically looking at losses that are in the moderate or mild region. So average hearing less than 70 decibels. With word recognition scores that are good. You know, we make it louder and the kiddo can hear it. We don't necessarily recommend traditional hearing aids for losses that are more significant than that, because typically we do see poor word recognition on that side. And so if we take a radio station that's going out of tune and turn it up, we've made it a loud bad signal instead of a better signal. So we don't want to take a bad signal and make it louder to compete with the normal ear that's a good signal. We also actually physiologically, once we get above 70-ish decibels, we'll start to vibrate the bones of our skull at a loudness that the other ear will hear. So we call that crossover. And so we will actually make it so loud that we will start to amplify the better hearing ear and provide sort of like sound on the better hearing side that is not sound coming from that side. And that can be confusing and create noise that we don't necessarily need. But if we are able to fit a hearing aid for a kiddo with one of those losses, then we're able to provide them with that binaural listening and build pathways to the brain from both sides, truly giving them bilateral stimulation and bilateral hearing.
That was a lot to take in.
So we have sensory neural hearing loss, which is a problem in the cochlea. The sound comes in and we have that loss, so it gets smaller, so less sound goes to the brain. Okay. The hearing aid puts bigger sound in, and then it goes to the brain at a normal volume. And so we're able to combat the sensory neural hearing loss by providing them with more sound. So that is how a hearing aid works. We give more sound to the system, and so therefore more sound goes to the brain. Okay. So I have this sweet little person who came in and failed her kindergarten hearing screening. Mom doesn't have any hearing concerns. She has some speech concerns. She's had some articulation difficulties in the past, but really they're here because she didn't pass the pediatrician screening. When we do our hearing test, we find that she does in fact have mild hearing loss on the left ear and normal hearing on the right. If you look down in the bottom right corner, you can see our speech scores. And you can see at a soft conversation level of 40, she gets 100%. And then we make it audible for her in the left ear at 60, she gets 100%. So we make it louder and it's easier for her to hear. So what should we do? In this instance, mom was like, well, she's doing fine. You know, I don't know that she needs a hearing aid. So we started talking about some of the other symptoms of hearing loss. And as we delved into it, come to find out that mom's about to have her tested for ADD because she is all over in the classroom. She's having huge behavior troubles. She can't sit still. She's not staying on task. but nobody's even begun to think about hearing loss for this child. So we decided, because of all those other issues that mom was seeing, that we would try a hearing aid and to see if we could give her, good hearing on both sides. We fit her with a mild gain hearing aid. And now she is 10 years old and she loves her hearing aid, wears it avidly, and does really, really well with it. If we look at her aided testing, you remember that score at 60 decibels was 100. Well, now it's 100 at 40, just like her right ear. So her hearing is more symmetrical. She's hearing from both sides instead of one. And then we look at her speech and noise testing. This is in the aided condition. You can see that no matter where we're presenting the sound from, the front, the good ear, the bad ear, she's able to hear all the different sounds. So she's doing really well with her hearing aid, and we did not have to test her for ADD because she did much better in the classroom when she could hear what was going on. So this is a situation where even though it's a little mild loss, and even though she's getting by just fine, not having any speech concerns, adding a hearing aid for this kiddo, and giving her full access to sound on both sides made a huge difference for her. Crazy. Okay. So our second subset of unilateral hearing loss is our conductive hearing losses. These are the kids that are missing an ear, have unilateral microtia or atresia. In older kids, sometimes you see this type of hearing loss in kids that have had cholesteatoma and had major ear surgery. But these are the kids that their cochlea works just fine, but the sound is not getting to the cochlea well. Typically, we find that kids with this type of hearing loss, when we have a difference between how they hear through the earphone and how they hear through the bone conductor of more than 30 decibels, so they have a hearing loss essentially of 40 decibels or more, we find that they do better with bone conduction technology than a hearing aid. So even the kids that have an ear that we can put a hearing aid into will typically do better with a bone conduction device than an air conduction device. And part of that is because they're able to get all those soft sounds of speech. The other thing that we need to consider when we look at this population is that we don't get true binaural hearing, that actual two ears working together as one, if our bone lines or our underlying sensory hearing at the cochlea is not at least 10 decibels within each other. So if you have one hearing ear that's hearing normally and another hearing ear that's hearing in the mild range, but we have this conductive hearing loss, we're still not going to achieve that binaural hearing because we don't have two ears that are together. So that's something to consider for our kids that have mixed hearing losses, just as sort of a side note. Generally, we do recommend we fit these kids with hearing aids as soon as possible because we are stimulating an auditory pathway and therefore we're growing the neurons in the track from the ear to the brain. It can be a little challenging with our soft band hearing aids to fit those on little bitty guys because we do want them sat on the correct side of the head. And those kids are like always surrounded by fluff because they can't hold their heads up and things like that. So you end up with like a whistling hearing aid all the time. And so it can be a challenge, but typically by 6 to 9 months of age, when kids are starting to like explore and crawl and sit up more independently, we can introduce a device with very easily. And then younger than that, if a parent is really motivated, we can use the device during like tummy time and situations where they're not always surrounded by soft things. So just because a baby is little doesn't mean we can't fit a bone conduction device. We can fit them very early on. So again, we talked about conductive hearing losses. The way that I explain this to my patients is that we have put like a brick wall in the system, whether that be, cholesteatoma or the absence of an outer ear. We have stuck a wall in the middle of the system. So we have the sound come in and it gets smaller in the wall. So less sound goes to the cochlea and then to the brain. So if we use a traditional hearing aid, what we've essentially done is we've taken the sound and driven through the wall. We've had to turn it up loud enough to make it through the wall. And if you've ever taken your car stereo or your boombox and turned it up really loud, at some point you start to get this like fun distortion sound with it. And even though hearing aids are great, they kind of do the same thing. As you start to get louder, it does start to distort things. And since you're going to a nice, healthy, normal cochlea, that child hears that distortion. And that's why you oftentimes see kids do better and honestly like the sound quality coming from a bone conduction hearing aid than a traditional aid, because instead of trying to take the sound and shove it down the system, what a bone conduction aid does is it actually takes a detour and it goes around the problem and goes right to the cochlea at a nice normal volume without a lot of distortion and gets it right to the brain. So we're not powering through the problem, we're going around the problem. So if you take a bone conduction device that's fit for a conductive hearing loss and you put it on your head and you have normal hearing, you probably are not going to be able to hear it. It's very soft. You have to take your hands and plug your ears. Now you've given yourself a conductive hearing loss and voila, now you hear the sound. So there's not a lot of volume going through this system. It's just sound being presented in a different way. And so these kids do very, very well with this technology. So in this case, I have a young man who was 18 years old. He had unilateral microtia and atresia and some hearing concerns with it. He had a severe rising to moderate hearing loss in the ear where he didn't have an ear, which makes sense. He's done very, very well in school, getting ready to go to college, makes great grades, but sometimes he has trouble, you know, in busier environments. And for whatever reason, he's made it to 18 and never had any type of amplification or tried anything. We did some speech and noise testing, and we found that when everything's coming from the front, he compensates quite well. He got 96% correct. And then when we go to that hardest situation where we go direct to the impaired ear, we do see that he has some struggles there. He drops down to 72%. So he's catching most of what's being said, but he does have sort of an area where he struggles to hear what's being said to him on that side. So we decided to go ahead and trial a bone conduction device in the office and see what he thought. And when I put this softband on this young man's head, he started to cry because he had never heard sound from that ear. And he was so overwhelmed by the fact that he could actually hear from his ear that he was just overwhelmed by it. So there is a group of people who don't necessarily think that unilateral microtia is something that needs to be aided immediately. And I would point you to situations like this and how much they get from it. I'm having 2 ears. We were built for 2 ears. We're able to give a kiddo 2 ears. Let's give them 2 ears. And in this case, I really think it's part of you don't know what you're missing if you're missing it.
Yeah.
You know, if you are in a busy room and somebody talks to you and you miss what they're saying from the right side, then you don't know you missed it because you missed it. And so it's not uncommon for this population of kids to tell their parents, I hear everything the teacher says. Well, how do you know you hear everything the teacher says? Because if you missed it, you missed it. So it's definitely something that we have to kind of explain as kids get older, that they do have struggles and they do miss things in theory. But in this particular instance, this young man decided to move forward with a surgical bone conduction device. He's had it now for almost 4 years. And you can see in the aided conditions that side where he was struggling a little bit has improved up to 96% from 72%. And now he doesn't have sort of that dead zone where he's not hearing as well as he should be. He loves his Ossia. He wears it all the time. So he's doing great, not having any trouble, A student, but still found benefit in a device. So you don't have to be failing to have benefit.
Yeah.
Okay, so those are kind of the easy kids. We have a hearing loss, we can fix it. Let's fix it. Then we get into this world of single-sided deafness and these kids that it's much harder to fix their hearing loss. If we have a loss that can be aided, when we see these kids, we do typically try to put a hearing aid on them and kind of see how they do. So if we've done the imaging and we see that they have a cochlear nerve and everything is intact, we will program a hearing aid, sometimes a little conservatively, so we don't cross over. But we'll fit a hearing aid and we'll see how they do. Typically, they don't do well with it. But we will test to see, because occasionally we find a kiddo that actually does get some benefit from a hearing aid. We also make sure we do the speech and noise test battery with these kids. And so if we find a kiddo that the hearing aid's not working for, and we have normal anatomy, we are now starting to consider cochlear implants for these kids. What that means is that we are able to actually provide binaural listening to them. So we're able to provide a pathway from the ear to the brain on that side, like the other side. It is an area of lots of research right now, and there are varying opinions on what and how we should treat these kids. Pretty consistently, we are finding that we need to have normal or near normal anatomy in order for the ENT surgeon to say CI is okay. So we're not going to put a cochlear implant on a kiddo that has a diminished nerve, because we don't know what kind of signal we're going to be sending to their brain. And we don't know if we're making a bad signal bad. And it's a lot of surgery to go through as a tiny person to potentially not get a whole lot of benefit out of. The other thing we look at is how long the child has been unaided. So if we have a child who's 10 that wore a hearing aid for the first 6 years of their life and then slowly progressed to profound hearing loss, then that kiddo sounds like a great cochlear implant kiddo. But if we have a kiddo who's 10 that we don't know when the hearing loss started, we know it's been there since at least kindergarten, and they've never had any type of technology or any type of hearing really on that ear that we know of, then we start to get a little more cautious with the outcomes for those kids. Again, kids are not tiny adults. You will find studies in the adult world that says that length of deafness of 10, 15 years, that these people are still doing really well with unilateral cochlear implants. But you have to think that if a 50-year-old person lost their hearing at 35, well, they had 35 years of hearing and building a system before they lost their hearing. So while they had 10, 15, 20 years of hearing loss, they developed a system that we can then sort of dust off and reawaken. If we have a kid that maybe never heard or didn't hear very well from the beginning, now we have like computer parts that have never been put together. And we're trying to turn on a system that was never built. And so we do find that in that particular population, we've been finding that some of those kids are not as happy with the sound, and many of them are becoming non-users. This is an area of super active research, and so there are varying opinions on this. But in our center, we've sort of put 5 to 7 years of unaided loss as kind of like the point where we started to say, I don't know that doing all of this surgery and things like that is going to have the outcomes that you hope for. We have done it for a few kids that are older, and we've had mixed outcomes. I have one little girl that lasted like 3 months with her cochlear implant before she put it on a shelf. But I have a colleague whose kiddo has it and really doesn't get great benefit traditionally, but likes to wear it. So you're like, okay. So I think it has to do also with expectations. I think if we get to the area where we're in this more than 5 to 7 years of unaided loss, that it's not necessarily that we can't do a cochlear implant, but the outcomes of what we expect to be able to do with that ear are very different than like a child who lost their hearing yesterday and we put a cochlear implant in. So it's lots of counseling and understanding what that difference is. But this is an area that's growing, and it's an exciting area. One of the things that's super exciting about, I have my fun slide, sorry. So cochlear implant, again, the problem is at the cochlea. The nerve goes from the ear to the brain, but the problem is at the cochlea. So in this instance, we put the sound directly into the cochlea and it goes to the brain. We don't worry at all about the front end. So there's a wire that goes up into the cochlea. We put that sound right into the cochlea and it travels up the nerve to the brain. It's a completely different way of hearing. It involves learning how to use that hearing, which involves our friends Sarah and Sarah who are coming up in good therapy and practice and full-time use. I have a lot of part-time hearing aid users that use them during school and not at home, or using during the school year and not during the summer. That is not going to work with the cochlear implant. It's full-time use all the time. So all of those things are expectations we need to set on the front end. So one of the things about cochlear implants for single-sided people in general is it's a really kind of exciting time in research. Because if I tell you to remember the color dress that you or your date wore to your prom, you could probably be like, purple, it was purple. But if I tell you to color match it with a color sample, you'd be like, yeah, I can't do that. And that's kind of what we're asking these people, like these adults that had hearing a long time ago, to do. We're like, okay, remember what hearing used to sound like? Okay, now match it. And so that's what we've been working with up to this point with bilateral hearing loss, is people maybe heard before and they can tell us what it sounds like, but do they really remember what sounds like? With this population, we have a person that has a normal ear on one side and a cochlear on the implant on the other side, and we can truly compare them. And it's pretty cool. I think we've had some interesting things. I thought this video was really interesting because oftentimes you'll hear samples of what cochlear implants sound like, and they always sound kind of robotic or cartoony, and you're kind of like, I mean, it's better than nothing, but it's kind of weird sounding still. And this little girl is a single-sided deafness cochlear implant user, and actually in the moment matches what her implant sounds like versus the normal hearing stimulus. And it's quite impressive, I think. So here we go.
Make sure the sound is done.
Tell me if it doesn't work.
I'll play it in that ear first, and then I'll play another one, and you say yes or no. Sound good?
The sun is finally shining. The sun is finally shining.
No.
The sun is finally shining.
You want to hear the first one again?
The sun is finally shining.
No, it's not that one. It's not that one? Okay.
The sun is finally shining.
No. What does it sound like?
It sounds like a demented robot.
The sun is finally shining.
Okay.
The sun is finally shining.
It's really close, but it's like, it's like, that, but it needs to have like more white noise kind of.
The sun is finally shining.
I think it needs to go down one more.
So do you think the other one was closer, or this one?
I think that one was closer. But
Okay, so let's try another one.
The sun is finally shining.
that's closer.
Okay, so we'll listen to this and tell me what you think.
The sun is finally shining.
Sounds like singing.
Is it really high pitched?
Yeah.
That one's flat. So is it sound like really flat sounding?
Kind of sounds like flat singing.
Yeah. Is that that's not closer than the other one? Okay. So we'll listen to this one and tell me.
The sun is finally shining.
Can you replay the one?
Yep.
The sun is finally shining.
Gosh, it's like really, 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 really close.
That's really cool. Okay.
The sun is finally shining.
That's one you think sounds really close. What would change if you could change it?
Like, can you say a little bit?
Yeah.
The sun is finally shining. The sun is finally shining.
Like, it's kind of like white noise in the back a little bit. So like white noise, and then it's clear, but it kind of like like if there's a wall and and there's two people on either side, if you talk over the wall, it's not going to be as clear. So kind of like that, like white noise.
Like muffled?
Yeah.
All right, ready?
Mm-hmm.
The sun is finally shining.
You play this one?
Mm-hmm.
The sun is finally shining.
Does it need more?
Yeah.
More like you're talking over a wall? That's what it sounds like.
Or like if you look closely your mouth and it's muffled.
Mm-hmm.
The sun is finally shining. The sun is finally shining.
Maybe try one
more. Like, did that sound closer, you think?
Yeah.
Okay.
The sun is finally
That's it.
Wow.
Okay, let me play them back and forth a couple times.
The sun is finally shining. The sun is
Yeah.
finally
Cool.
shining.
Why is it so loud?
It's how she's perceiving it.
Hmm.
So, but it's pretty cool. We can actually like see what it is that she hears, and she's able to match that. And so we're also able to make, in research purposes, direct comparisons to like how they do timing and how they do pitch and lots of different things. So I think there's going to be some exciting research coming out in cochlear implantation because of this population. And what I found most exciting was that it didn't sound like a demented robot. It sounded like a person. So, because that is one of the big concerns I get from patients who come in who have normal hearing on one side, is like, I found this sample and it sounded like a crazy, scary robot. I don't want to do it. And you're like, but it's not. Like, that was our guess. And our guess was, maybe you remember at the beginning, those were like kind of what we used to say cochlear implants sounded like. And she's like, y'all are crazy. That's not what this sounds like. So I do think it'll be interesting to see. There's a cool thing about this population that we're going to be able to help everybody with an implant, I think, because of what these people can tell us. So in this particular case study, we have a 5-year-old friend whose mother noticed that she's having a hard time finding where sounds are coming from in her grandmother's house. Don't have any speech concerns, getting ready to start kindergarten. And the only other sort of concern they had was that when they get in really loud places, she covers her left ear and gets kind of upset. So we came and did a hearing test and found that she had profound hearing loss on the right side, and maybe just a little bit of hearing loss on the left side as well. But overall, the left ear was pretty close to normal. Her word understanding at an average conversation, when we used both ears together, she got all of them right. So she was able to understand average conversation well with both ears, which is good. And so we decided to see what she did with like a cross device on. So we put a bone conduction device on to try to give that left ear a little better access to the right side. And we found at 0 that she came in at 97%, which is good. In speech to the, excuse me, sorry, this camera is right where I need to see. Okay. When we put the sound to her poor hearing ear, she had a really, really hard time. She only got 5% correct. And so we put on the device and we see the score at 0 stays about the same. The score to the better hearing ear is really good. She gets 100%. So that's still easy. It's not making it harder for her. But then it really doesn't help her at all. We put the device on and she still can't hear anything we're saying from her right side. She improves to 7%, which is not an improvement. So we have this device that maybe would make it easier for her left ear to hear, but it's not really helping her. At this point during our testing, we did not have imaging yet. So we brought up the idea of a cochlear implant for her and said we needed to do some additional testing. But what did the parents think if this was a possibility? And so what they decided to do was actually move forward with cochlear implant. So she did have normal anatomy on both sides, and they did get an implant for her on the right side. She had surgery in January of 2021. And interestingly, in this case, she is one of those kiddos who actually had progressive hearing loss on the other side. So most recently, when we tested her in September of 2022, you can see her right cochlear implant. She is achieving really, really well. She got all of the words correct and quiet. So she's able to understand beautifully with a cochlear implant now. But her left ear, which was her good ear, is now really, really struggling. So the parents are beyond thrilled that they picked a cochlear implant for her, because now that is the ear she's using to hear.
Yeah.
She is slated to get a second cochlear implant actually in May. So this is one of those situations where she was 5. We didn't exactly know when the hearing loss had started, but she had well-developed speech. The parents did everything right, you know, as far as the cochlear implant. They did isolated listening with the cochlear implant. They did auditory verbal therapy with the cochlear implant, and she has really thrived and done very, very well with it. And it was actually a really hard decision for them to go with the second side. But she's been on a bit of a roller coaster where her hearing hasn't nicely gradually shifted. It's been going up and down and up and down and up and down. And so we're going to take her off the roller coaster and give her good hearing on both sides, hopefully in May. But yeah, so she was one of our first single-sided kiddos at our center, and she's like a poster child. She's done very, very well with it. So it's awesome. So again, we do have a large population of these single-sided kids that are not going to be cochlear implant candidates. Upwards of 25% of them are not going to be a cochlear implant candidate. That's why it's super important and often preferred before we talk to them and do all these evaluations that we know what their imaging looks like. Because how much fun is it to tell a parent about all the opportunities they have with cochlear implant and then be like, actually, never mind. It's way better if we kind of know what we're walking into. So most audiologists are going to ask that before we really start talking about solutions for single-sided deafness, that we have done some imaging to figure out what options are available to the family. So why is this important? Cochlear nerve deficiency, what's the big deal? We have a pothole. Okay, we have our ear, we have our ear bones, our cochlea, and then the nerve that goes from the ear to the brain has a pothole. It doesn't let the sound through. So we have our hearing aid bringing sound in, and we get stuck after the cochlea. We have our cochlear implant that takes sound right to the cochlea, and we get stuck on the way to the brain. We have our bone conduction device, which reroutes sound beautifully to the cochlea, but it can't get to the brain. We can't get sound from the ear to the brain when we don't have a healthy cochlear nerve. So all of the options that we've talked about for all these other kids, those are not choices for these children. We cannot get the sound to their brain. So what can we do? We don't need to throw our hands in the air and be like, well, we just can't help you. There are ways we can make things easier for these kiddos, but we can never truly restore the binaural hearing or the binaural neural stimulation. We can't reactivate that ear because there's no pathway from the ear to the brain. These kids, it is imperative that we do speech and noise testing for them and really see how much their hearing loss is affecting their ability to understand and how much their hearing loss is affecting them to develop speech. These kids, we really have to watch. These are also the kids that if they have lived like this for a long time, so they're like 8, 9, 10, and they've compensated quite well, introducing to technology, sometimes it's more of a hindrance than a help. So it is really important that we make sure we're testing both with and with the devices off to really tell us whether a child is going to benefit from the devices we're offering, or whether we need to come up with a different solution for them. This population is also often ones you'll hear people say, well, they got a hearing aid, but then they never wear it. Anecdotally, in my practice, I have found that the children who achieve really well without the hearing aids, so there's those kids that score 80, 90% with the device not on, even in the hardest situations, tend to be the ones that are like part-time users, and like they use the device sometimes, but it's, they don't need it to get by, or that's how they feel. Whereas the kids like my friend from before, where she like truly cannot hear anything on that side of her head, those kids wear their technology religiously and get huge benefit from them and absolutely love them. So this testing can give us sort of a good way to counsel our families. If you're going to tell someone this is going to change their life and they're not really struggling, it's not going to be like an oh wow moment, or if you're able to say, look at all the things you missed and then look how much easier and better it was, you can get a 13-year-old kid on board to be like, oh yeah, you're right. I do have trouble with that. So it's a really powerful counseling tool, as well as a way for us to ensure that our technology is helping and not hindering. So we have different ways to do a contralateral routing device. We have what's known as a cross hearing aid, which is actually 2 hearing aids. One is just a microphone and the other one is actually a hearing aid. And so the microphone sends the sound from one side to the other. And so you essentially get 2 ears worth of data into 1 ear. But what you fix is that head shadow effect. And so you're able to get sound faster from the impaired side to your better hearing ear. So it's kind of like taking a microphone and putting it across the room to hear that part of the room easier. You're still only doing all your processing, all your listening with 1 ear, but it's making it so that the sounds that were previously harder to have access to, you have better access to. Okay. In adults, it's pretty easy to fit. In kids who have teeny tiny little ears, we have an additional challenge, which is that when we put the hearing aid in their good ear, we've now put an earplug in their ear. So we had to make very sure that we have that fitting as open as possible. So we're not creating a hearing loss by trying to help with a hearing loss. So it's really important that we do testing with the device in place to make sure they're still understanding as well as they were without the device. We can do different types of testing, both with real ear and in the booth to kind of take a look and make sure that that is happening for them. One way that we can combat that easily is through a bone conduction device. Nothing goes in the ear, so we don't have that problem anymore. Under 5, we fit them on soft bands, and that bone just vibrates the bone and it's picked up by the other side. Cosmetically, having a headband on as a 5-year-old boy is not something that a lot of them like. So we do have surgical options once they hit 5 years of age to allow them to have access to that technology without having to wear a headband that's tight and maybe doesn't look great. So I'm talking about this device and I'm trying to give you guys a better example of what it looks like. We have a right ear that's not working, a left ear that's working. Without our device, the sound comes in and we have to wait for it to go all the way over our head and then come back into the left ear. If we add a cross device, we get the sound coming in and it pops right over the left side and gets heard. So it just makes it easier and faster for that sound to get to the left ear, but the left ear is still doing all of the lifting, all of the work. So we have a friend, he's 9 years old. He passed his newborn hearing screening, but the parents weren't sure because they said one ear took longer than the other to pass or something. After many years, he was identified with profound hearing loss in the left ear, normal hearing in the right. A CT scan showed that he actually does have a diminished cochlear nerve on that left side. And so we looked to see what we could do to help him with. He's struggling in school. And mom's trying to decide if he's a 9-year-old boy that's having a hard time in school or if his hearing is really helping him, making him struggle. So we did speech and noise testing, and again, to 0, he does really well. He compensates well, 94%. But then when we put the sound to the left ear, we see that that's where he struggles. He drops down to 25%. So he's got this dead zone that when anybody's over on his left side, he can't hear as well as he's supposed to. So what we decided to do with this kiddo is an actual cross hearing aid. He chose it due to comfort and cosmetics. He really likes his cross aid. And mom reports he's been doing much better in school. He actually reported to me just the other day that he got ribbons at school because his reading and his math scores have improved so much. So that was awesome. For our aided testing, we did speech and quiet with both ears together to make sure that he is still having no trouble hearing really, really well. He gets 100% with the device in place, which is what we want to see. And then if we look into the noisy environments, we see to the front, he still does great at 92. When we go to the better right ear with the device in place, even though we're adding a little bit of extra noise, it's still really easy at 96, which is great. And then in that difficult listening situation where he was at 25%, that score is improved to 81%. So he gets a huge impact of the device. He's able to hear and understand what's happening on that side of his head much, much easier. And he absolutely loves his device now. So yeah, this is a kiddo that's done really well with the device and what we can do with this type of technology for these kids. This kiddo here, we have a severe to profound hearing loss on the left. She tried a soft band around 18 months of age at a different facility, but they decided to wait because they were having a hard time keeping it on. She had an MRI ordered, but it was never completed, so we don't know the cause of her hearing loss. She is also struggling in noise. We see that in that hardest listening condition, she's down to 20%. And then at the front, 96 doing well. We talked about different choices and parents decided they wanted to go ahead and trial a bone conduction device again for her. So we did it and she is fit with a soft band device. We see that at 0, she's still at 94%, which is good. To the better ear, she's still getting great access. And to the impaired ear, she's getting improvement. We're not at 20%, we're at 59%, but she still struggles quite a bit in noise on that side. She wears the device at school, but refuses to wear it at home and says she likes the device okay, but doesn't really love it. She definitely has not embraced the technology as something that's awesome for her, but she does admit kind of begrudgingly that it helps her. We have used this testing and the device to help her in school and also show the school system that even though she's wearing her hearing aid, it's still really challenging for her, you know. So the importance of having her in the correct placement in the classroom as much as possible, adding an FM system to her in the classroom potentially would be beneficial for her. And we've discussed with this family the idea of considering a cochlear implant for her, but we don't have the imaging results, so we don't know if that's truly a possibility till they have that workup. So some benefit, but not great benefit. So we have the exact same hearing loss, 2 kids, both doing relatively well in school, very different outcomes. This is the gray. We don't know till we test. And so this is why this population is so hard to pinpoint and say, yes, this is definitely what we do for this kid, because you can do this test 10 different times and get varying results. So the importance is the testing of each kid and making sure that we're looking at each child truly as their own little puzzle to figure out what's going to help them. No technology, totally an option. Some kids, like for example, the last kid, she decides it's really not helping her that much. She doesn't want to wear a device all the time. She's doing well with her schooling and her speech and language. And so in this situation, we wouldn't put a device on her. We would just monitor. Definitely, we wouldn't let her go. We wouldn't be like, okay, peace out. We would let her go. We would keep track of her, make sure we're monitoring the normal hearing ear, and that she is continuing to maintain normal hearing on that side. Continue to watch her speech and language and her schoolwork, make sure she's not struggling there. Watch for any behavioral signs like extreme fatigue or attention in the classroom. And if we're noticing classroom issues, we could potentially bring in the idea of an FM system for the better hearing ear in the classroom to help in that situation, while not necessarily doing technology all the time. So there's lots of options that aren't necessarily technology all the time for these kids too. If that, for some of these kids that do really well to compensate, but then we want to make sure they're catching everything in school. We can give them technology in school, but not all the time. So I believe this is my last case study, and this is one friend again with microtia atresia. No other significant medical history. She is older. I want to say she's 16. She's never tried any type of device. She does well in school, but sometimes she says she has trouble in noisier environments. We went through the speech testing, and as you can see in the unaided condition, she does really, really well. Her score is like 91% to the impaired ear, and she's got like a solid, moderately severe hearing loss on that side. With the device on, it's a little bit easier, but it wasn't that hard without the device. So she was like, yeah, I mean, I can hear small sounds. It's kind of cool, but I mean, I don't really need it. And I kind of agree. She does pretty well without it. She's making good grades. She's being successful. And so if it's working for her, it sounds good. So we'd want to continue monitoring her hearing and make sure that the hearing on the good side is good. Want to make sure that we're continuing to counsel about conservation on the good side, so she's not going to like rock concerts and blowing out her good ear. And kind of just keep her in our sights and make sure that we're continuing to do this testing every once in a while, because also what happens now doesn't mean that when she's in 5 or 6 years and she's in a different environment that she doesn't maybe want to reconsider and try something at that point. But this is the case where we decided that she was doing pretty okay on her own. So they're not tiny adults. It is a significant hearing loss. There's lots of ways to treat them. And so the key points are making sure we treat every kid like their own little puzzle, and that we take a look and see what we can do for each kiddo. So there we go.
That was so good. I love that. We do have questions that we're going to see. And I also want to note, after we're going to do questions for 10, 15 minutes. After that, we're going to take a break, and then we're going to start back at 3 o'clock. All right. So Nikki, what is our first question? I thought we could, can you bring up the question? Yeah. We're gonna look at the questions that we have.
Yes.
I'm gonna start with Erin.
Are you able to see them?
We're gonna try to pull them
Maybe.
up. Maybe. Are there, I mean, so we answered the statistics, right? Are there statistics regarding the success, lack of success of the children who are monitored no technology?
I'm not sure about that. To my knowledge, I have not found a paper that specifically addresses that. They tend to bundle all of these kids into one big bundle of unilateral hearing loss. So you've got kids with mild losses and single-sided deafness kind of all bunched together. But I will look into that and let you know.
We have another question for adults with single-sided deafness following surgery due to acoustic neuromas. Do you recommend Baha or cross aid?
I think that's going to be super personal. I have some patients who really like the way cross sounds, and others that hate it. I think generally what I have seen is that the Baha is a little bit better accepted as far as the sound quality. Also cosmetically, you only have one hearing aid instead of two, which a lot of us are excited about. So I probably would trial both in the office and kind of see which one they preferred, because in theory, they both work exactly the same. So you really shouldn't see huge differences in the benefit from those two devices. But it'd probably be more of a personal choice on that front.
Let's not do Samantha's yet because of this. What are the costs of these treatments?
That's going to vary hugely.
Especially with insurance, right?
It's going to vary hugely with insurances and the type of treatment that you're looking at. I mean, a hearing aid costs a couple $1,000. A cochlear implant will cost $30,000, $40,000. So, I mean, like grossly different. It's going to depend on what you're looking at.
Are you finding that insurance companies are covering a CI for unilateral, or they're fighting back?
We haven't had a ton of fight back. I think we did have one recently. Technically, by FDA standards, I want to say it's 5 is the actual age that you can implant. And so trying to do it younger, we've had some insurance companies kick back with that. But for the most part, we've had pretty good success.
Because the insurance wants to see if they're successful.
No, because the FDA says you can't do it below 5. So they're like, well, FDA says you can't do it below 5. So even though, just because that's what the studies have shown, so that's what the FDA says, even though we know it's better to do it earlier for all the reasons that we know about cochlear implantation, it's been approved by the FDA for 5 and up. So the insurance is like 5 and up. It's been approved by the FDA. So that's one of those are the rules type situations.
I think that's
it will get better with age or with time as we get them lower. For CI for congenital hair loss anatomy, is there a cutoff?
Say it out loud. So
okay, do you consider CI for congenital hearing loss if their anatomy is okay? Is there a age cutoff? Yes, if anatomy is okay, we can absolutely do a cochlear implant for those kids that are congenitally deaf, but that goes back to more research is sort of needed. Our clinic is 5 to 7 years of unaided deafness. So if you have a kiddo who is born congenitally deaf in one ear and they're 10 and they've never worn a hearing aid, then we're going to counsel you that the likelihood of them liking and actually getting great benefit from the device is less so than like a 4-year-old who is in that same situation. And again, it goes back to building the system. They never built a system. So we're trying to awake a system that never got built.
To that one next.
Have you noticed any difference in performance or need for technology based on the side of hearing loss? So there has been anecdotal things that have been talked about as far as right versus left hearing loss. The right ear has direct access to the left side of your brain, which is where your language center lives. And so there was always this thought that if you had hearing loss on the right side, you'd be more impaired than someone with hearing loss on the left side. But there actually have been some studies that have shown that that ear difference is not as measurable, at least as we had initially thought. So no, we don't see that difference as large as you would think. Yeah.
All right, so we're going to go to the top with Samantha's, and then we'll work our way back down. Please keep bringing on the questions. We're going to do questions for 5 more minutes. And then after that, Nikki is going to post the quiz. Right? Oh, you have it.
These are posted already in the chat and they're on the screen.
Okay, make sure you copy that link and save it so you can take that quiz later. All right. What do you recommend?
What do you recommend if your child is testing with mild hearing loss, but the teacher says he's doing great with no issues in school? I think this population and the mild minimal hearing loss population fall into that a lot because they're not failing typically. They are working their tails off to do as well as everybody else. So I would say that in that situation, doing testing in the audiology room can definitely kind of try to quantify how much trouble they're having. And in my opinion, if a loss is aidable, we should absolutely aid it because again, we have 2 ears for a reason and we know our brain works best with 2 ears. So if we're able to give any person 2 ears, that's what I'm going to recommend. Even if the teacher says they're doing great, think about how much potential they could have if they're not working to listen to what's being said, but working on learning what's being taught.
Do they wear an earplug in the good ear during therapy or mapping appointment?
Oh, single-sided deafness mapping is a beast of its own. That is a moving target right now because it is near impossible to get rid of the good ear with like earplugs and things like that. We do our best to mask the good ear, but what we have found is one of sort of the best ways at the moment to test is to actually use some of these Bluetooth devices that the companies have to use the microphone and test their device like directly through a microphone as opposed to our speakers. So we're truly isolating the implant. I think some of the therapists are doing similar therapy. They'll do the therapy on the internet and actually do therapy from another room so that they're only going to the implant because it is really hard to isolate that. How does the cross device affect the child's spatial awareness? It doesn't. There is extensive research that shows that cross devices and bone conduction devices for single-sided deafness really do not improve localization at all. So if we're looking from like did the localization scores get better? It's been proven over and over again that they really don't. However, anecdotally, we do have parents people report that they can kind of hear a sound quality difference between like the microphone sound and the ear side to give them a hint of where sound is coming from. So
Nikki's going to answer. Someone didn't see the quiz. Wanda, Nikki's going to respond to you probably with the quiz, I would imagine. I have a question. Do you feel that auditory verbal therapy is an essential part of being diagnosed with single-sided deafness, that the family should look into that?
I think that auditory verbal therapists are very special people because they are trained in all of the speech and therapy and also the hearing aspect of things. And far too often, I feel like I see people say, oh, well, they're saying 10 words at 18 months, so they're doing great. And there's a lot more to language and listening than that. And this group of therapists really knows that and is able to keep these kids on target. So my opinion is that any child with hearing loss should meet with the auditory verbal therapist and at the very least kind of be monitored with their progress and kind of see how they're doing. When it comes to cochlear implantation, though, yes, 1000% yes, they need some auditory rehab or therapy to get that ear up and running.
Shout out to AVTs.
That's right.
Don't know. Nikki, did we answer all the questions so far? I don't want to miss anything. I'm going through so much stuff right now.
You should only look at the ones that are under open. I've marked all the other ones off. I don't know.
That's why I'm like, where'd they go?
Yeah,
we did the cross.
I think I
Yeah, we
answered
did that one.
Okay. And we are.
All right,
Yes.
please, we're gonna keep this open. We're not gonna turn this webinar off during our break. We're just probably gonna mute. But like I said, we're gonna start back up. Nikki, do we agree? Give everyone 15 minutes?
We'll resume right at, plan to be back at 2:55. We'll make sure everything is up and running. Sarah will start with their presentations at 3 o'clock on the dot because they have a lot of great information to share and they're going to use every single minute.
Yes, good point. All right, we'll see everybody back in 10 minutes. Thank you so much. This was amazing. I know people enjoyed that. I'm glad this is recorded so that people that weren't able to show up can see it later. I was even getting texts during the session of families that couldn't get their kid to go to bed or whatever and really wanted to see it. So they're gonna get that and they don't need to get the CEU credit. So cannot thank you enough. We will see everybody back in 10 minutes. Have a good break.